Good evening, ladies and gentlemen. On behalf of the Chest Council of India, I welcome you all to this apt webinar, which at this point of the time, and especially in this season, the very need of an hour. Flu, the three-lettered word, which also means grippe, has indeed gripped the mankind since aeons. This disease is chased from the family physicians to the super specialists. If left alone with time to heal or a timely intervention, it's a good disease to have. But in special people with poor immunity, it's catastrophic. To unravel the facts and for the take-home clinical pointers, I have with me an astute team of panelists across the country. Dr. Rakesh Chawla from New Delhi, Dr. Ravi Dosi from Indore, Dr. Supreet Batra from New Delhi, Dr. Vrushali Khirid Khadke, a great buddy from Pune, Dr. Shweta, Gargiya, my dear friend from Ahmedabad. We would have a brief presentations on diagnostics of influenza from Dr. Shweta, then the management guidelines by Dr. Ravi Dosi, which would then be followed by a brief talk on vaccination by Dr. Supreet Batra. Lastly, we would have a panel discussion with the take-home editorial points from each and every astute panelists. Firstly, I would like to give you a very short and crisp information on the history and epidemics of this disease. So, ladies and gentlemen, records show that flu has been around for at least 1,500 years. The history of influenza begins with Hippocrates, that's from the 5th century BC, who first reported that an influenza-like illness spread from northern Greece to the island south and elsewhere. In the 1300s, a flu epidemic hit Florence, Italy, which they called influenza di freddo, that is cold influence, no doubt a reference to what they thought which caused the disease. The Spanish flu we all know, a pandemic of 1918, known as the murder of all pandemics, was the deadliest pandemics ever, impacting 1/3 of the world's population and killing an estimated 50 million people. More US soldiers were dead during this flu pandemic rather than they died in the World War I. In 1997, humans were infected with a highly pathogenic avian influenza A, that is H5N1 virus during a poultry outbreak in China. Most of us remember 2009, a new strain of influenza A, H1N1 virus became a pandemic starting in North America and spreading worldwide, killing over 2 million people, which is on record. Influenza has an immense global burden and an impact globally. Globally, about 5 to 10% of adults and 20 to 30% of children develop influenza A or B each year. Influenza-associated respiratory deaths are estimated to correspond to approximately 2% of all annual respiratory deaths globally. And as per the global burden of disease from 2017, influenza lower respiratory tract mortality was higher in low to middle income countries compared to the high income countries. And nearly 1/3 of all influenza LRTIs deaths occurred in India, that is 26,000, followed by China 11,000 and Russia 8,000. Recently, we have seen a surge in influenza cases in India. Most of these cases are due to influenza virus A, H3N2. If time permits, and once we are done with the panel discussion, I would read a report which I have got it today itself from the Ministry of Health and Family Welfare, where they have given a report on influenza, report 2023. So, ladies and gentlemen, let's start with our presentation. Dr. Shweta, who is going to highlight on the diagnostics of influenza.
So first of all, I would like to thank all the audience and CCI to give me this opportunity to be present today in front of you. I would like to discuss a very important topic today, that is influenza. That how we diagnose our patients of influenza. Should all the patients of whom we are suspecting to have influenza should be tested or not? And which patient should be tested for influenza? So, which patient should be tested for influenza? All patients, including the emergency department patients, during the influenza activity, which is defined as the circulation of seasonal influenza A and B virus among persons in the local immunity. Clinicians should test for influenza in high-risk patients, including immunocompromised persons who present with influenza-like illness, pneumonia, or non-specific respiratory illness, cough without fever, if the testing results in influenza clinical management. Patients with influenza who present with acute onset of respiratory symptoms with or without fever and either exacerbation of chronic medical condition, example asthma, COPD, heart failure, or known complications of influenza like pneumonia should be tested. Clinician can consider influenza testing for patients not at high risk for influenza complication, but who present with influenza-like illness, pneumonia, or non-specific respiratory illnesses, and who are likely to be discharged home if the results might influence the antiviral treatment decision or reduce the use of unnecessary antibiotics. Further diagnostic testing and time in the emergency department, or if the result might influence antiviral treatment or chemoprophylaxis decision for high-risk household contacts. During the low influenza activity, clinicians can consider influenza testing in patients with acute onset of respiratory symptoms with or without fever, especially for immunocompromised and high-risk patients. Whereas in hospitalized patient during the influenza activity, clinicians should test for influenza on admission in all patients requiring hospitalization for acute respiratory illnesses, including pneumonia with or without fever. They should test for influenza on admission in all patients with acute worsening of cardiopulmonary disease like asthma, COPD, coronary artery diseases, heart failure, as influenza may exacerbate the underlying conditions. Clinicians should test for influenza on admission in all patients who are immunocompromised or at high risk for complications and present with acute onset of respiratory symptoms with or without fever. Clinicians should test for influenza in all patients who, while hospitalized, develop acute onset of respiratory symptoms with or without fever or respiratory diseases without a clear alternative diagnosis. During periods of low influenza activity, clinicians should test for influenza on admission in all patients requiring hospitalization with acute respiratory illness, with or without fever, who have an epidemiological link to a person diagnosed with influenza, an influenza outbreak, or outbreak of acute febrile respiratory illness of uncertain cause, or who recently traveled from an area with unknown influenza activity. Patients with acute febrile respiratory tract illness, especially children and adults who are immunocompromised or at high risk of complication, or if the results might influence the antiviral treatment or chemoprophylaxis, or they are contacts of household who are at high risk of complications, then influenza testing should be done. Now, what is the best specimen for influenza testing? So, we should collect the upper respiratory specimen for influenza testing as soon as the illness onset is possible, preferably within the first 4 days of the onset of the symptoms. Nasopharyngeal sample is the most useful sample. If it is not possible, then we can take a nasal or a throat swab specimen and combine together for influenza testing over single specimen from either side. Mid-turbinate nasal swab specimen should be collected over throat swab specimen. Flocked swab specimen should be collected over non-flocked. If it is not possible to collect the nasal or the throat samples, that is, patient is on mechanical ventilation, then in such cases, we may use endotracheal aspirates or bronchoalveolar lavages. We should not collect or routinely test specimen for influenza from non-respiratory sites, such as blood, plasma, serum, CSF, urine, or stool. Now, what are the available tests? What is the mechanism? What do they diagnose, detect? Can we differentiate between the various A subtypes? How much time it will take? And what are their performances? The first test, which is most commonly used, is the rapid molecular assay. It depends on the nucleic acid amplification. It detects the influenza A or B viral RNA. It cannot differentiate between the A subtypes. Usually, the result is obtained between 15 to 30 minutes. It has high sensitivity and specificity. The rapid influenza diagnostic test, it detects the antigens. It helps to diagnose the influenza A or B virus antigen. It does not differentiate between the A subtypes. The result is obtained between 10 to 15 minutes. It is having low to moderate sensitivity with a high specificity. Immunofluorescence assay, whereas it may be direct or indirect. It depends on the antigen detection. It detects the influenza A or B virus antigen, cannot differentiate between the A subtypes. The result is obtained between 1 to 4 hours. It is having moderate sensitivity with a high specificity. Molecular assay, which includes the RT-PCR, the most sensitive and specific test, it depends on the nucleic acid amplification. It detects the influenza A or B viral RNA, differentiates between the various A subtypes, usually takes 1 to 8 hours with a high sensitivity and high specificity. Multiplex molecular assay also depends on the nucleic acid amplification. It not only detects the influenza A or B viral RNA, but also the other viral and bacterial targets. It can differentiate between the various subtypes. The test is obtained between 1 to 2 hours with a very high sensitivity and specificity. The rapid cell cultures and viral cultures can also be used, but they are not that very useful in the routine clinical practices. So, what test should be used by each clinician? So, a clinician should use rapid molecular assay, that is nucleic acid amplification test over rapid influenza diagnostic test in outpatients. They should use RT-PCR or other molecular assay in hospitalized patient. They must be using multiplex RT-PCR assay targeting a panel of respiratory pathogens in hospitalized immunocompromised assay. If any other organism is being suspected apart from the influenza, then multiplex RT-PCR test should be done. The clinician should not be using any immunofluorescence assay for influenza virus antigen detection unless and until we do not have an RT-PCR or other molecular test for the follow-up testing. Viral cultures may be used only if we want to confirm the negative result from the rapid influenza testings and the immunofluorescence assay. So thank you. This is what are the tests which are available for the diagnosis and when each of the tests should be used.
A very good evening to all of you. I would like to thank Dr. Shweta ma'am for such a good presentation on diagnostics of H1N1 and swine flu and influenza related seasonal flus, which we all are commonly going to face or are already facing in some parts of the country. I would like to give my heartful thanks to Krishna sir, who despite being injured is so actively guiding us for our presentations. And I would like to thank Dr. Sonia Dalal ma'am for the moderator of today's program. Well, how do we manage these cases? Dr. Shweta has very effectively told us how to diagnose these particular flu-like illnesses, but how do we go about managing them? Well, the management is based on certain principles like infection control precautions, which have to be immediately instituted, because as we commonly see that it is not an isolated case of flu that we see in a family or in a community. The moment we diagnose one case, we start getting several cases. We need to institute prompt treatment. What is that particular prompt treatment? And most importantly, like already has been told in the previous presentation, early identification and subsequently follow-up of these particular cases, particularly the high-risk individuals. That is the guiding principle of management of seasonal flu. Now, how do you manage? Where do you manage? First of all, such patients come. We are all very fresh from the COVID infrastructure that had to be set up. We need well ventilated isolation wards with the beds being at least a meter apart. We need dedicated manpower for this particular sort of a situation, because at times when flu cases come, there are an infectious outbreak, mini outbreak sort of situation. You get 2-3 admissions, or maybe almost 7-8 patients of a similar sort in the OPD. So we need a dedicated manpower for that particular situation. We need equipment dedicated to that particular flu or influenza managing unit, where you need dedicated beds, dedicated X-ray, portable X-ray machines. You need proper supplies. Supplies include everything from your PPE kits to your medicine stocks of oseltamivir, and to your IV fluids and oxygen supplies. So the standard operating procedures begin with the reinforcement of standard infection control procedures or precautions. We should restrict the number of visitors to such patients, and overall the number of visitors, and whenever there is an infectious viral outbreak, should be limited in the hospitals. And if they do so they should be provided with PPE. Antiviral prophylaxis, we will be discussing about whom to give, whom not to give, and most importantly, waste disposal of such cases should be done very, very properly. These, believe me, are very essential parts of the management of these particular viral illnesses. Now, if we talk about this particular situation, that when should an antiviral be started? Should we wait for this particular report to come in? Should we wait for any particular vaccination history? Well, the recommendation says persons of any age who are hospitalized with influenza, regardless of illness duration prior to the hospitalization, should be started with antiviral immediately. OPD patients of any age with severe or progressive illness, regardless of the illness duration. OPD patients who are at high risk of complications from influenza, like those suffering from chronic medical conditions like heart condition, dialysis requiring patients, or immunocompromised patients, should be started on antiviral as soon as possible. Children younger than 2 years of age or adults more than 65 years of age have a very strong recommendation of being started on antiviral as soon as possible. Pregnant women and those within 2 weeks postmortem can and should be started on antiviral as soon as possible, because the studies very clearly told us that antivirals work when you start them as early as possible, within hours of the initial symptoms to up to 4 days. If you start your antiviral medication, then the chances of recovery are as high as 96%. So it is very important to start antiviral as early as possible. Now, clinicians can consider antiviral treatment for adults and children who are not at high risk of influenza complications or with suspected history, in patients who are having OPD illness with an illness onset less than 2 days before presentation, who are symptomatic outpatients, who are household contacts of a person who are at high risk of developing complications from influenza, particularly those who are severely immunocompromised, symptomatic healthcare providers, that means you and me, for patients who are at high risk of developing complications from influenza, particularly those who are severely immunocompromised. So several of our colleagues who might be suffering from diabetes or who might be on other sort of medication for arthritis, they have to be very strongly considered for starting of antiviral prophylaxis whenever they are tending to such sort of patients and they have a high chance of becoming symptomatic. The standard medication is oseltamivir. The dose for treatment is for weight less than 15-30 milligram twice daily for 5 days. For more than 40, which is our most common age group, is 75 milligram twice daily for 5 days. For infants, it is available in the syrup form, which is coming as 12 milligram per ml. So you give 12 milligram twice daily for 5 days, up to 25 milligram twice daily. That means 1 tablespoonful or 2 tablespoonful. Now, one very important point to be noted over here is that the IDSA guidelines very clearly tell that there is no sense of doubling the dose, even if you're treating a patient more than 40 kgs. So if there is a common practice in obese individuals, or at times even when we see severe cases, that we have a practice of doubling the dose of oseltamivir from 75 to 150 milligram twice daily. But IDSA guidelines do not support that particular practice, and telling that there is no guideline or no trial-based advantage to that particular practice. Now, what is oseltamivir? Oseltamivir is basically a neuraminidase inhibitor. What do they do is these viruses, they attach to the receptors and enter the cell. The neuraminidase inhibits the new virion release, and this particular action halts the viral replication and contributes to the antiviral activity. It is a well-tolerated molecule. It has GI side effects like nausea, vomiting predominantly, more if you use a higher dose of up to 300 milligram per day. It may cause bronchitis, insomnia, and vertigo. All of these complaints are seen at times in patients who have been on oseltamivir. It may even cause angina, pseudomembranous colitis, and peritonsillar abscesses have also been reported. Rarely, anaphylaxis and skin rashes are seen. In children, when you give the syrup form of 12 milligram twice daily or 24 milligram twice daily, vomiting may be seen. Infrequently, abdominal pain, epistaxis, bronchitis, otitis media, and conjunctivitis have also been observed. There is no recommendation for dose reduction in patients with hepatic disease. Though rare, reporting of fatal neuropsychiatric illness in children and adolescents have been linked to oseltamivir, though there is no cause-effect relationship which has been established. Now, there is another newer antiviral also which has been started to be used in Japan. It is available by the name of the pro-drug, which is baloxavir marboxil, and baloxavir is the actual antiviral. It acts on viral mRNA transcription activity and thereby affecting the transcription. It inhibits the replication of the viral RNA genome and further replication of the virus. But again, it is an under trial molecule. In Japan, they are using it highly. Why we should consider this? Well, because nowadays influenza resistance is also being talked about. So when do you think about influenza resistance? When patients who develop this particular form of influenza despite being on prophylaxis, in immunocompromised individuals who are persistently influenza positive despite being on treatment, in patients who are having subtherapeutic neuraminidase dosing, and patients with severe influenza who do not improve with treatment. Well, all of them should be considered strongly for neuraminidase resistance, and in them we have some molecules apart from oseltamivir. Baloxavir is one which I talked about. The others are amantadine and rimantadine, and then there is zanamivir and peramivir. Important thing is amantadine and rimantadine, anti-Parkinsonian drugs which act on the M2 protein. They are resistant to H1N1, but to other influenza viruses, we can give a try if resistance is suspected clinically or microbiologically proven. Zanamivir is given in an inhalational form. It too is a neuraminidase inhibitors, but it can be used in children more than 2 years of age and can be given a try. And then there is peramivir, which is given IV. Once daily dosing is there. Resistance is not reported in H1N1 cases also. So we have some drugs available for resistant cases or suspected resistant cases, namely baloxavir and zanamivir and peramivir. Now, when should we suspect bacterial co-infection, or should we start IV antibiotics in these particular cases? Well, in a patient who initially presents with a severe disease like extensive pneumonia, respiratory failure, hypotension, in addition to antiviral, we can start IV antibiotics as per your community-acquired pneumonia guidelines. If there is deterioration after initial improvement, then you should start antibiotics. And if the patient doesn't improve, 3 to 5 days of antiviral treatment is given, still the patient is not improving, then you should consider IV antibiotics. Supportive therapy like IV fluids as per the patient's additional symptoms. Parenteral nutrition is very important. Oxygen therapy, antibiotics for secondary infection as per the guidelines which I talked about previously, and vasopressors for shock. Now, supportive therapy like paracetamol or ibuprofen is prescribed for fever, myalgia, and headache. The plenty of drinking fluid should be advised. The smoking should be avoided. Topical decongestant, saline nasal drops can be given. We have to remember that salicylates or aspirin are strongly contraindicated in any influenza patient due to the potential to cause Ray's syndrome. We have to monitor these cases regularly. Their vitals like respiratory rate, saturation, and level of consciousness should be monitored and noted every 6 hourly. The patient with signs of tachypnea, dyspnea, distress, and a saturation less than 90% should be supplemented with oxygen. The oxygen device can be anything ranging from a simple nasal cannula to a Hudson's mask to a partial or a complete non-rebreathing mask. In children, we can use oxygen hood or head boxes. The supportive therapy is indicated when the saturation is 90% or PO2 is less than 60 millimeter with oxygen therapy. Such patients are in acute respiratory failure. In them, mechanical ventilation has to be instituted if the patient is having a depressive consciousness. Non-invasive ventilator are of plus or minus evidence-based benefit. HEPA filters have to be used in expiratory circuits for the protection of the atmosphere. Health workers, airway, breathing and circulation need to be maintained. We need to maintain hydration and electrolytes, and adequate nutrition has to be seen to. Immunomodulating drugs have been shown to have no added advantage. Corticosteroids have absolutely no added advantage for the hypoxia part. They rather have a potential for harm. The low dose steroids may be useful in persisting septic shock of 200 to 400 milligram per day, hydrocortisone, and other immunomodulators have not at all been found to be of any benefit. This is a recommendation by the IDSA guidelines as well as your CDC guidelines. The antibiotic therapy, like I told, prophylactic antibiotic therapy if it is a case of severe pneumonia and if the patient is on ventilator. Otherwise, it is not required for your mild to moderate cases. Mechanical ventilation, you straight away put a patient on ventilator if he is on severe respiratory failure with a saturation of less than 90% with an FiO2 of 0.6. The recommended settings in guidelines are a controlled mode with pressure preset setting with a tidal volume of 6 ml per kg and a rate of around 30 to 35 per minute. The other methods to use if your hypoxia is refractory to your conventional ventilation is airway pressure release ventilation and inverse ratio ventilation. For rescue therapy in case of severely hypoxic cases, you can institute recruitment maneuvers, use sedation, neuromuscular blockade, and even give a trial of prone ventilation if the patient permits and if the staff is well tuned to it. You discharge these patients ideally in adults 7 days after the symptoms subside, in children 14 days after the symptoms subside. But commonly, we tend to manage these patients at home, and such a prolonged stay nowadays is not seen in our routine clinical practice. So we have to monitor these patients much more effectively. Now, I would like to pass on the mic to Dr. Batra sir, who will be talking about vaccination, because prevention is the best. And again, I would like to end by thanking CCI for giving me an opportunity to talk on management of flu-like illnesses. Thank you.
Hello, good evening, everyone. I am Dr. Supreet Batra. The topic for today is influenza vaccination. Thank you, Dr. Ravi, for a wonderful talk. And at the outset, I would like to thank CCI for giving me this opportunity. So as we all know, there are two types of influenza vaccine. One is inactivated influenza vaccine. The other one is live attenuated influenza vaccine. Though there is robust data on its safety available, but the data on its effectiveness is lacking. That's why the Indian guidelines prefer inactivated influenza vaccine over the live attenuated influenza vaccine. Inactivated influenza vaccine, it can be egg-based, it can be cell culture-based, or it can be recombinant influenza vaccine. Out of these, only egg-based are available in India, and they are only of two types, that is trivalent vaccine or a quadrivalent vaccine. Then which one to choose, a quadrivalent vaccine or a trivalent vaccine? However, they differ only in the Yamagata or the Victoria B strain, but there are certain advantages of quadrivalent vaccine over the trivalent vaccine. It gives additional protection against the circulating B virus. It causes reduction in morbidity, and it is cost effective. So that's why quadrivalent vaccine should be preferred over the trivalent vaccine. Then what should be the dose and the frequency? The dose recommended by the various guidelines is single high dose of inactivated influenza vaccine should be given. But this is unavailable in India. So the standard dose, that is 0.5 ml, is to be given. What do we mean by standard dose? That is 0.5 ml of vaccine contains 15 micrograms of hemagglutinin or neuraminidase antigen, whereas the high dose contains 60 micrograms of hemagglutinin and neuraminidase antigen. So frequency, it is annual vaccination is recommended. It reduces mortality by 10%, and revaccination reduces mortality by 15%. Then whom to vaccinate? It is recommended that all adults more than 50 years should be given one dose annually. Between 18 to 49 years, it is based on the discretion of the doctor and the choice of the patient. However, there are certain groups which are at higher risk of influenza complications. So these patients should be vaccinated, like patients with diabetes, chronic renal disease, patient with chronic liver disease, patient with neurological conditions, patient with cancer, and patient on long-term steroid therapy. Patient with heart disease should be given upfront, and there's a grade 1A recommendation in those patients with heart disease. Patients with asplenia and sickle cell disease and living with HIV also should be given upfront influenza vaccine. There's grade 1A, 1B recommendation. And all medical personnel, those who are looking after casualty, emergency, or ICU, or working in screening centers and looking after influenza patients, even laboratory personnel, rapid response team members, and also the drivers and staff should be given upfront influenza vaccine, and there's a grade 1A recommendation. Coming to chronic respiratory disease, like patients with COPD, bronchiectasis, interstitial lung disease, and chronic smokers should be given 1 dose annually, except asthma, where there's a little debate. But the various guidelines, ACIP guidelines recommend vaccination asthma patients, and also our Indian guidelines recommend that those with chronic persistent asthma should be given 1 dose annually. Pregnant women can be vaccinated with influenza vaccine, should be given any trimester of pregnancy. Now, when to vaccinate? There was a WHO FluNet database conducted in 125 countries, and it was found that Indian database was found that 70% of influenza positive cases seen in June to November, and 30% of influenza cases were seen in December to May. So basically, influenza is throughout the year in India. Then when to vaccinate? So those states who are having a peak influenza season in late winters, like December to May, after December, in those states, patients should be vaccinated between September to October. And those states who are having a peak influenza season between June to November, in those states, patients should be vaccinated between April to May. Hence, the recommendation for influenza vaccine is to consider local epidemiological data for peak seasonality rather than the WHO hemisphere classification. And that's why there's a dire need for national surveillance data for influenza peak seasonality across various Indian states. Contraindications. The absolute severe allergy reaction to influenza vaccine is an absolute contraindication. Those who had moderate or severe illness with or without fever, or those with a history of GBS within 6 weeks of receipt of influenza vaccine, precaution should be observed in this group of people, and they should be observed. However, those who have experienced, those who have egg allergy and experience only urticaria, age-appropriate influenza vaccination can be given. Or those who have experienced more than urticaria like respiratory distress, angioedema, or those even required epinephrine injection can also receive age-appropriate influenza vaccine. Then what are the drugs? Those who are taking antiviral drugs either for treatment or chemoprophylaxis, inactivated influenza vaccine is recommended in those group of people. Patients with chronic pulmonary disease, those on long-term steroids, can also be given influenza inactivated vaccine. The benefit outweighed the risk in this group of people. Similarly, for statins, we know they reduce the effectiveness of influenza vaccine, but still the guidelines suggest that these people should also be given the vaccine because the benefit outweigh the risk. Then co-administration with other vaccines like COVID-19, yes, it can be given at a different anatomic site. It can be given with conjugated and unconjugated pneumococcal vaccine concomitantly or sequentially. It can also be given with herpes zoster vaccine, which is a live vaccine. Only 4 weeks gap have to be observed with live attenuated vaccine. Then vaccine for travelers recommendation. All travelers, all individuals, irrespective of their vaccination station, should be given the influenza vaccine. And it should be given 2 weeks prior to the travel. And the strain should be chosen according to the circulating other travel destination, maybe northern hemisphere or the southern hemisphere strain. For Hajj pilgrims and mass gatherings, it is recommended irrespective of the influenza season at the home or the place of visit. The basis for that is people coming from different geographical areas have different influenza peaks activity. Therefore, these people can catch or contract infection from them. Regarding the storage of the vaccine, it should only be stored out in a refrigerator with a temperature range of 2 to 8 degrees Celsius. The vaccine should never be frozen or stored in a door of a refrigerator. Household refrigerators are never recommended, and for transportation, always use cold chain. These are my references, and thank you for your attention. Now I would like to hand over the stage to Dr. Sonia Dalal ma'am for moderation. Thank you.
Can we start with the panel discussion now? So can I have Dr. Chawla, sir, who's the senior most and most respectable in the CCI group? Sir, can you just explain why did we see this upsurge, in the cases of influenza in 2022 and 23 post-COVID, and there was a great upsurge? Are there any reasons for that, sir?
Thank you very much for putting a strong foundation for the discussion by Ravi, Supreet, and Dr. Gargiya. Thankful CCI family for inviting me for the discussion. And you have rightly said COVID-19. If you go back to this pandemic of COVID-19, you have not seen influenza virus in 2020 and 2021 because of the immobility, lockdown. People were not moving. They were not on the streets. There were all kind of COVID protocols being followed. And literally 2020, it was a silent year for influenza. The situation in 2021 and 22 has been more difficult to interpret. The heterogeneity in magnitude and timing of the influenza activity globally can be partially attributed to the diversity of COVID-19 control strategies. So if you see this with ever-changing program of COVID-19, and especially now when the COVID-19 issues are subsiding and you are seeing the surge of the influenza activities and the influenza presence. And the literature says if you see the COVID-19 and influenza, they counter each other and each other's presence. So now when the COVID-19 is going, you have to be ready for the surge of influenza activity.
Chawla, any reason that we all, just missed the vaccinations during the COVID times? We were all after the COVID vaccines, and most of the patients probably, missed taking up their influenza shot, the flu shots. Can that be also one of the reasons?
See, that is a very, very important reason. And the disorderly, what they write is the disorderly return of influenza now brings up new questions for control. One, will influenza seasonal patterns return to normal after COVID-19? Should the timing of influenza vaccination be altered? And should influenza campaign be synchronized with COVID-19 immunization? Should the current scheme for designing the composition of the annual vaccination be revised and to see and contain the influenza infection and the influenza contamination and the spread? These are very important questions which are coming up and we have to decide. And definitely no influenza vaccine in between is also responsible for what we have seen.
So very nicely and very aptly, concisely said by Dr. Chawla. Very important is that we all were, close bound into the homes, and that was the reason that there were no mingling and hence no flu. After 21, 22, once the lockdown and things opened up, probably, there was a lot of mingling and people were in close contacts, and then everyone was only after the COVID and taking COVID vaccines. And one of the reasons that's the reason the flu aggravated the H3, and we see the upsurge in January 2023. So let me come down to Vrushali. Vrushali, if you have a patient with fever and multiple lung infiltrates, cough, right, and has no comorbid condition, and you are admitting the patient without doing, and the test is negative. If the test is negative, what would you do? I mean, would you start the patient upfront on oseltamivir?
So you said a patient who has no comorbidities. First of all, thank you so much, CCI, for inviting me. Thank you so much, Sonia Madam, and all my co-panelists. It is a pleasure and a great honor to be with you all. So, Sonia, I'm sorry, I did not get the first part. It is a person who has had no comorbidities.
So, no, if the patient has no comorbidities, the patient is, has an X-ray with bilateral infiltrates, cough and fever, and the, patient tests negative for influenza. and he comes post monsoon, and then that's probably the time that you are thinking that influenza is starting to pick up. Would you treat the patient upfront, or would you probably work up for other differentials as well?
Yeah. So Sonia, brilliant question is, one is, what is the timing at which the patient has been tested? So up to 4 days of the patient symptom onset, yeah, we have a great sensitivity and specificity of the test. Beyond that, if you already have lung infiltrates, where I would prefer to do in a BAL and send the entire molecular assay rather than just going for influenza. And I would err on the side of treating this patient for influenza in a highly active area, that is your influenza season. So I will treat this individual with oseltamivir and whatever would be the local guidelines at that point in time, as in, whatever is your community acquired pneumonia, and we'll consider the atypical infections in this. And once we have this results out, where you might, which generally takes around 3 to 5 days, you might consider withdrawing or not withdrawing based on how the patient is responding. So like I said, more than 4 days and lung infiltrates already, I think we should consider doing a bronchial aspirate or a bronchoalveolar lavage and sending that sample, because by that time the NP, nasopharyngeal area, doesn't have the virus. It is more in the lower respiratory tract.
Perfect. So for the audience, the timing of the presentation of the patient is very important. If the patient comes during the flu season, so we have 2 flu seasons in India, then strongly suspect in spite of RT-PCR being negative. If you have an excess and you can do a bronchoalveolar lavage, do it straight away. And still, wait for the reports, but you can always start empirically, even if the RT-PCR is negative. I hope I'm clear. Is it correct? That's what you're trying to say, Vrushali? Is it correct?
Yes.
Correct then. Okay.
Yeah, I am doing away with the small thing that, the way you have collected the swab may not be accurate. I think that is something we all know.
Yes. Of course, I agree. I don't deny that. This is only, I would have straight away started the patients on the drug, the patient had a comorbid condition. But a young patient, no comorbid condition, fever, infiltrates, you still have time. So, you can do all the workups. And still, in the seasons of flu seasons, you can always give an empirical antiviral.
I would also like to point out, Sonia, that during the 2009 pandemic, H1N1, the initial phase, we had all patients with comorbidities. But a year later, I have this collection of data where the patients who came with severe needing hospitalization, NIV, or ventilation, ARDS, were actually individuals between the age group of 30 to 54 without any comorbidities.
Sure. So, could you please just elucidate on the sensitivity and specificity of the RT-PCR? Though Shweta has covered up very nicely, but
actually, yeah, I would still say that. So, what I had also discussed was Shweta clearly told it very clearly that it's a very good sensitivity and very good specificity. Now, sensitivity can be a problem if your collection is not right. She's also differentiated very well between the nasopharyngeal collection, the nasal, the middle turbinate, the nasal and the throat swab. And in this case, like the patient which we had infiltrates, where we would like to go in for a bronchoalveolar lavage. So these are the factors where the sensitivity can be a problem. The duration of the patient's symptoms. So if you do it beyond 4 days, of course, it can come negative. But also what has been mentioned is that each kit comes with its own, there is the microbiologist tells me that there is written that, you have a sensitivity, this much is the sensitivity. So generally 90-95% is the sensitivity and the specificity of the RT-PCR.
So that means that even if the RT-PCR is negative and if you're strong suspecting, you have all the reasons to treat the patient, correct?
Absolutely.
Correct. All right. Supreet,
the right clinical scenario, season, yes.
Of course. Thank you. Supreet, how do you clinically diagnose a susceptibility of the drug to the virus, clinically? Because it's very difficult. We don't have viral cultures, nor do we do any sensitivity patterns, and the patient is clinical. How do you do it clinically in the ICU or in the wards?
Yeah. So when we start antivirals, we should definitely assess for a response. If a patient is not responding to treatment after 3 to 5 days of treatment, is having continuous fever, or he is testing positive after a PCR, RT-PCR, or he has a progressive disease despite on treatment. So these are the indications that patient is having some resistance to the drugs, or he has got a resistance to antiviral. So in that case, we can suspect that he has got a resistance clinically. But to diagnose it, we need viral cultures and to do viral culture will take a long time. So I think these are the pointers which point us that there might be some resistance to the antiviral and the patient is not responding.
Supreet, what would you do clinically in that patient? How would you approach? I mean, clinically, such patients, when you either there is a reduced susceptibility or a patient has got some another, pathology.
Yeah. So it can be. So there can be other things also, like if patient develop septic shock, hypotension, or breathlessness, or maybe on onto a ventilator. So definitely we can do multiplex PCR to diagnose concomitant infections, maybe atypical bacterial infections, and we can do even procal also to identify the secondary bacterial infection or not, so that we can come to know whether it's it's a resistance to the neuraminidase inhibitor antivirals, or the patient has got a secondary bacterial infection. And then if a patient has a bacterial infection, maybe shock due to the Staph aureus streptococcus pneumonia, and then we can start empirical antibiotics. So that is how we will approach if we have clinically to diagnose any resistance, or the patient is not responding to our drugs, or maybe having a secondary bacterial infection.
Correct. So what do I understand from your trailing is, if the patient is not responding to the drugs, we need to investigate whether the patient is having a low susceptibility or a resistance to the drug. Or the other thing is, we also rule out the other infections like bacterial infections or any other infection per se. So we send all the cultures, we send all the other parameters to rule out the infection, right? If we find that, we treat that as well. And if all those things turns out to be sterile and everything is normal, we can probably, add on some other antiviral to the neuraminidase inhibitors. That's correct.
Rightly said. We can change to the newer antivirals.
So would you combine the M2 inhibitors, which Ravi had shown, along with the neuraminidase?
No, ma'am. Actually, there's no recommendation to use amantadine and amantadine. Correct. There's no recommendation.
Correct. All right. Ravi, can I come to you?
Yes, ma'am. Yes, ma'am.
So when can a person recovering from a COVID, we have been probably, very well jittery with the COVID though. So if a patient is recovering from a COVID, what would be the right time to take a flu vaccine and vice versa?
Well, ma'am, really a tough question. I'll begin with the good news. Krishna sir just called up to inform that we have 1,014 logins just now watching this webinar. So
that's fantastic. Yeah, that's good.
Coming to the question, ma'am, well, the right time to take a flu vaccination, well, there are two things. Post-COVID, one is if the person is been recently infected with COVID, then definitely there should be a difference of at least 2 to 3 weeks from his infection to the vaccination. And secondly, if the patient has received a COVID vaccination himself, then also there should be a gap. Although I don't have any authentic proper time.
So how much gap? Supreet, can you highlight on that?
Please.
What Ravi said is, if patient has active infection, we should wait. But previously we were observing that there has to be a 2 weeks gap. But the guidelines have come up clearly that there should be no gap. It can be given simultaneously with the COVID vaccine, but at a different anatomic site. So it has not.
I'm talking about a patient developing, coming out from the COVID infection. I'm not talking about giving COVID vaccine and the flu vaccine. If a patient is recovered from COVID, how much time he has to wait to take a flu shot?
So normally the recommendation by the government was minimum 3 months you should wait. Correct. Yeah, so that was the recommendation. But giving vaccines together, there is no interaction. Though there should be no gap between the vaccines.
Supreet,
can you highlight? Yes, Dr. Chawla.
I believe whatever said and done, it's always better. Patient is coming out of COVID infection to wait for 3 months what government says or what government does not say. Right? It's better to wait for 3 months and then give. There is no emergency of using the flu shot, right? And patient is already naturally vaccinated with COVID in an epidemic of COVID. So I think it's always better.
And also one thing is, you will not be able to identify whether he has got post-COVID complications or a complication due to a vaccine, an adverse reaction due to a vaccine.
Correct.
Ravi, can you just highlight upon the vaccine in pediatric age group, please? Ravi? Dr. Ravi?
Sorry.
Am I audible? Ravi, there is a question from the audience. Vaccine in pediatric age group. Supreet?
uh, we have discussed about the adult vaccination, but for children, it is usually said that they can be given vaccination right from more than 6 months. So the inactivated influenza vaccine can be given right from more than 6 months age. Only for live attenuated vaccine, the age recommendation is more than 2 years. And again, there are some contraindication, but live vaccine is not available in India. So the recommendation is more than 6 months inactivated influenza quadrivalent vaccine can be given to all children.
And do you think that a multiple vaccine, so twice in a year, can be given up to the age of 8 years in the pediatric age group?
Right now, ma'am, there is no recommendation. Even it's a guidelines, ACIP guidelines.
The CDC.
CDC do not recommend biannual vaccination.
All right. So let me come to Shweta. Shweta, what would be the safety of a flu vaccine in a pregnancy?
Ma'am, it is very much safe in pregnancy also, but it should not be given in the first 2 weeks of first 2 months of pregnancy. But after that, inactivated vaccine can be given in pregnancy.
Okay. All right. And how common is GBS post-flu shot?
I didn't get you.
How common is Guillain-Barré syndrome post-flu shot? If everyone is so much petrified with GBS.
Ma'am, the only contraindication is having any severe anaphylactic reactions. The incidence of GBS after flu shot is very minimal. The exact percentage, I didn't get the percentage, but the ratio is very less.
It's shown in literature.
It's 1 to 2 per million. There's a
It's pretty high. It's 1 to 2 per million.
Per million. It's very rare. So there is a spate of different features, so it's quite less.
It's very less.
Dr. Chawla, sir, can a person flu in spite of being vaccinated?
Well, it is very, very important that patients who are vaccinated, they come to your clinic and tell, फिर भी हमें flu हो रहा है, फिर भी हमें pneumonia हो रहा है. You are giving the pneumonia vaccination, you are giving the flu vaccination, following regularly. The problem with influenza virus is there is an antigen shift and antigen drift, which is very, very common. And if you see the drift, these are the minor changes in H and N, what you say, these receptors. But if there is an antigen shift, that is a major change into the virus, and the whole virus itself changes. So during the flu season, it is not a surprise if there is an antigenic drift of the virus and patients are getting infected again, because if you see the effectivity of the vaccination, influenza vaccination is around 60 to 70%. It is not 100% that once you have got a flu shot, you will not get, but protection is very, very important, especially for those age 65 and above. As Supreet has said, 2 years and above you take it, rather than discussing the pediatric or an adult vaccination. 2 years and above should be all vaccinated for flu every year regularly, especially those we are with comorbid conditions should be vaccinated with no guarantee to them that they will not get it. But if the disease will be there, like in COVID, it will not be very severe. They will be saved from the severe disease. But the problem happens because of the shift and drift of the antigens, and it has to be monitored in every season by the virological institute.
So I think, with the diagnostics and with the therapeutics as well as vaccination, most of the points have been, covered by Dr. Ravi, Dosi, Dr. Shweta and Supreet. So what I'll now do is I'll give some of the clinical scenarios, which would be very apt for, the audience as well as all of us. And how do we approach patients as far as investigative modality is concerned, as well as far as therapeutics is concerned, and the vaccination. So let me start with you, Vrushali. And this is a 24-year-old female who's diagnosed case of allergic rhinitis, sinusitis, and asthma. Now she walks into the OPD. I mean, all these things are very important. She walks into the OPD as an outpatient, and she complains of cough, cold, sore throat, and occasional wheeze, right? Now, the first important thing for you is, she's walking post-July, that is after the monsoon. Now, how will you differentiate this patient from from influenza, whether this is a common cold or an allergic rhinitis cold or it's an influenza?
Sonia, some subtle markers can help us differentiate. So absence of fever because she's quite young. The other thing is absence of myalgia, particularly with any kind of flu-like illness or viral illnesses. There's a lot of myalgia. There can be fever, may not be fever in the age group less than 2.
Fever will never, fever is not an always the,
Yeah, so not, that's why I said it does not necessarily be a symptom. And, you do not have other things like, because there's wheezing. I wouldn't really consider if she has a good oxygen level. I would like to treat her as more of an allergic rhinitis or a common cold, which is worsening her symptoms. And we should be under close watch. So like in the flu season, generally, when we had the pandemic, we had this nice categorization of A, B, and C. So A were the individuals who did not have fever and they had no comorbidities. B were individuals who were categorized as those with comorbidities and high-grade fever, where you could start them or initiate them on oseltamivir straight away as a treatment. If you want to do the test, you do it, or vis-a-vis do not do the test. Category C was the ones which required hospitalization. So on this lady, what I would think, this is more of a common cold, though flu is likely, but I would, like I said, she'll be in a monitoring thing. I will treat her more with decongestants, plenty of fluids. Still ask her to, prepare protection, mask. I do that for most of my patients, and I'll just follow her. A slight exacerbation, treatment and slight exacerbation. Sorry?
Will you investigate for influenza in this lady?
No, Sonia, like Shweta has very nicely told the IDSA statement guidance, I wouldn't like to investigate this individual for influenza on a no-pity basis.
So, this kind of breakups happen when H1N1 is coming, H3N2 is coming, or H2 and H3N2 is coming. You know about it because the whole country. Now, recently what was happening? Just COVID, few cases and surge of COVID and H3N2, all country was reporting at par that everybody is getting in their ICUs H3N2 coming positive, from the clinic H3N2 positive. So it's really very difficult to differentiate which one is a flu, which one is a cold, which one is an H1N1, or which one is an H3N2. What you have to follow is the pattern and epidemiological data by the Ministry of Health, Government of India, that makes you aware now this kind of things are going to happen, and they are happening. And you are treating them as simple flu-like illness rather than treating them as H1.
So, sir, coming to you then, are there any good clinical and history pointers which would, take you towards the flu? You will have your pendulum shifted towards that.
See, it is very, very difficult when you get a patient who is coming with you a short history. Like incubation period is hardly 1 to 4 days. Family is suffering, the whole family is coughing, and they have cough. Like in COVID, you used to ask for a travel history. Very, very important. You picked up a travel history, patient has got fever, flu-like illness, cough, fever, myalgia, sore throat, loose motions, whatever symptoms which are all common. You say, oh, he's traveling from the COVID prevalent area, he must be having COVID, I must do the COVID RT-PCR. It's very difficult to point out that this patient has got H1N1 or this patient has H3N2, or it is a simple flu-like illness with presentation of all these fever, sore throat, myalgias, or nasal discharge, weakness, cough, other respiratory symptoms. So once the patient is deteriorating, if he has tachycardia and now the patient is developing desaturation, you need to admit him, then you investigate for everything. You will not stop at H1N1 only, because still you will send RT-PCR for COVID-19 viruses.
Vrushali, coming back to you, how will you treat a patient of, the scenario that I gave you? Would you think of giving this patient an antiviral, or you will just treat symptomatically?
So Sonia, like I just said, that I would defer an antiviral with her in case, like just pointed out, there's no tachycardia, there are no real signs of toxicity, or I'll monitor her in terms of, so it will just be decongestant, a small acute exacerbation of a pre-existing illness. is what I will be treating her. So it can be antihistaminics. I will avoid the glucocorticoids also at this junction, and just the inhaled glucocorticoids which she must be taking. I might up the dose if she is quite symptomatic. And like I said, I will ask her to monitor her terms. So if she becomes tachypneic, if there is fever which comes in, and if she has any tachycardia or even the oxygen desaturation. Now I think everyone has pulse oximeters at home. So that is what she would do, and plenty of hydration.
So what I can understand from what you said is that it's not, I mean, it's difficult to differentiate a common cold from influenza at this level. So you would probably just ask her to monitor her pulse, her temperature, SpO2 to a greater extent. Yes, by that time she'll always have fever and she'll have tachycardia and she'll come to you. You will give a decongestant. You would give a leukotriene inhibitor if you want to, and symptomatic treatment, and of course treat that little bit of exacerbation she has, that she started with a V, so you can probably think of giving her a rescue inhaler and all, and you will keep her under close observation for a week. Is that correct? And this has to go very clear and loud to each and every one, that such patients and such flus need not be investigated and need not be treated. Yes, a close observation and asking the patient to stay in touch for 1 week or 10 days is pertinent. Is it okay if what I'm telling?
Very loud and clear and perfect.
Should panelists agree to this? And this has to be very loud and clear to everyone, that because what we have seen during the COVID times is azithromycin has become a national drug, right? And the same thing had happened to oseltamivir in 2019 and 2011. Everyone, right and left and center, was using the antivirals. And it is very difficult for us to look at the poor susceptibility and also look at the resistance pattern of antivirals. So it's very important that we pick and choose the correct patient, what we use. I hope.
Sonia, definitely no antibiotics.
Of course not. Of course not. I mean, patient comes to us with a quinolones and augmentin and azithromycin
courses.
Nothing is to be given.
I suggest here, there should be a survey, especially the pulmonologist. What we talk here, we behave in our clinic. That use of antibiotic prevalent amongst the MD physician and the pulmonologist upfront in all influenza-like illnesses, and giving a strong message there is no use of antibiotics. These two disparities should be surveyed. That we must see and tell the truth to the country, that how many people are, how many pulmonologists, how many physicians are using upfront antibiotics. Let it be doxycycline, to levoflox, or to any, you can say, the cephalosporins. Then only the true picture will come. We all refute reading the Western literature.
ऐसे पेशेंट हमारे पास कहाँ आते हैं? ये ऐसे पेशेंट आते ही हैं,
लेके आता है एंटीबायोटिक्स लेके
आता है सर. In fact, you know what is happening? Azithromycin has been prescribed by the pharmacists. Now,
so what I want to say, he is one of us. When we say leke aata hai, he is one of us. So we should have a true national data of use of antibiotics or misuse of antibiotics in viral illnesses.
Perfect. I agree with you, Dr. Chawla. I come to Ravi. Ravi.
Ma'am.
Yeah, all right. So I'll give you one scenario. This is a 65-year-old lady. She's diabetic and she's diagnosed case of coronary artery disease. Now comes with excruciating dry cough for 7 days, sore throat, fever, and dyspnea on minimal exertion, which is maybe MRC 1 or 2. So in this patient, what investigations would you recommend?
Well, ma'am, an elderly with comorbidities is the basic there, but she seems to be not in, she's hemodynamically stable, maintaining saturation still, only severely symptomatic. So I would like to evaluate her by going for labs like CBC and her routine electrolytes. I would like to definitely go in for a chest X-ray, and I would like to take a throat swab for bacterial culture, as well as our testing for both your influenza things, and as well as maybe if the setting is there of COVID also in this particular case.
You would. And would you straight away start with the treatment of influenza, before waiting for the RT-PCR to come?
100%, ma'am. I think since there is a clinical setting, the patient is having comorbidities, is elderly, there are risk factors, then there is a chance of rapid deterioration. So I would start antivirals early in this patient, even before waiting for the drugs test to come in.
So clearly, Ravi, your therapeutic choices, A, B, C, D.
Well, ma'am, obviously, oseltamivir is the drug of choice, I would say, in this particular situation. Apart from that, symptomatic management in the form of analgesics or for throat, for soothing our throat. And I would limit myself to that, ma'am. Depending on the X-ray and labs, I would like to determine whether to use an antibiotic or not in our case.
Would you admit this lady, Ravi?
Definitely, ma'am. But the only thing is that, it would be a ward admission, more of observation, because there is chance of deterioration in her case. But I would prescribe admission to her. Yeah.
So very clearly what Ravi has said, I would probably repeat this. Yes, all the basic investigations, RT-PCR for H1N1, for influenza A and B, and also COVID RT-PCR. And of course, you would admit the patient in the ward for observation for 48 to 72 hours, whether she's deteriorating or improving. And once the RT-PCR is taken, you would also start an empirical antiviral if the patient comes in the time where the flu season is there, right? And of course, you would also rule out some of the infective other causes and observe the patient for 48 to 72 hours. Ravi, do you want to add this, or this is okay?
No, ma'am. I feel this is okay, ma'am. I'll continue.
Just monitor the patient for temperature, SpO2, and rest of the other things, right?
Yes, ma'am.
Sonia, I will add here, if
Yes,
your patient is admitted to you, turn-away time, if your hospital has got a molecular lab, is 3 to 4 hours. You get RT-PCR H1N1, H3N2 or COVID RT-PCR in 4 hours. So you are always safe before your patient is getting tuned to your therapy, and you know that you are giving exactly the antiviral patient needs or he doesn't need. Because these days it's very easy, 3 to 4 hours you get the report.
Many times what happens, RT-PCR, sometimes a false negative report also comes. So if the patient is in the flu season and if the patient has got some, you probably are justified in giving in such patients who has a comorbid condition.
You have to assess the whole scenario in total.
Exactly.
But this turn-away time which has reduced helps you to reach for the diet.
Of course. Though we get it in the evening. So if we set it in the morning, we get it in the evening. It takes around 6 to 7 hours at our place. So
no, you are correct. Depending upon the load of the sample, that's how the hospital reach.
Sure. Okay. Supreet, I'll ask you, this is a clinical scenario. This is a 55-year-old male, case of CKD, a chronic kidney disease with hypertension, not on maintenance dialysis, has a history of travel from UK in May 23 and presents with cough, breathlessness, fever, and cold. Will you admit this patient?
Yes, ma'am, I will admit this patient because this patient qualifies that he is a patient has risk for factors for, he's an elderly patient and also has a risk, chronic kidney disease and hypertension. So that qualify, if it is isolated hypertension, it's not a risk factor, but chronic kidney disease is a risk factor. So definitely he is at risk for influenza complications. So I will admit him.
You are giving me a diagnosis of influenza. So that comes to another question. How would you differentiate influenza from COVID from an atypical pneumonia?
So, ma'am, it's very difficult to differentiate between COVID and influenza, but there are some pointers that in patients with COVID, if patient is complaining of loss of smell, loss of taste, or any thrombotic complications, so that goes in favor of COVID. But actually speaking, I will test him for both multiplex PCR of doing COVID and sending a multiplex PCR so that I can test for COVID, influenza, and also for atypical bacterial infections, as all can be the possibility in this case.
Okay. And what should be your treatment plan in this patient?
So at the upfront, I will start him on at least antivirals. I will start him on antivirals because he qualifies for the influenza-like illness state.
There's a travel history as well, Supreet. He's coming.
Yes, ma'am. So, yeah. So that's what I will I will start him on antivirals. And this, since there's a travel history, I will wait for COVID report also. And if he's having desaturation or hypoxia, then I have to give him supplement with oxygen. And if required, if there is a desaturation, then A or PF ratio, some problem, then I have to start off steroids also. Because COVID-19 can be a possibility. And any viral illness, I know steroids should not be given. But if there is an element of hypoxia or patient is having PF ratio less than 300, then I think we should start low-dose steroids in that case.
All of my panelists are open to come and comment on this.
So on this, Supreet, I would beg to differ. So like Sir said that, we are doing an RT-PCR for the influenza as well as the COVID. Both are easily available. And for COVID, we even have the rapid antigen testing, which has a very rapid turnaround time, just 30 minutes. So I think, I would go err on the side of giving oxygen and remdesivir and see how the patient is falling. So if I get both tests negative.
So one more minute, CKD patient, Vrushali, the creates being very high, you will have to look at antigen clearances, and whether giving antivirals are again a threat to their kidneys. How do you do it? So I mean,
tell me something, and everyone, I would like to ask all the panelists that in the whatever number of cases you've treated, how many patients who had CKD you've not given remdesivir, or if they given remdesivir, and did they have any worsening? Anybody of you?
No, we did.
Thousands of admitted patients.
No, I agree with you. But then, we have given to thousands of patients, and this might be 1,000 patient who would probably,
So I am going on the side that where he said that we have a PF, the patient is, having low oxygen levels. So I said that is saying we have a turnaround time. In this case, we would also see that there is another bacterial infection which is there. Because he is a patient of CKD, is he also in fluid overload? So the same point comes when we were speaking about, the resistance to the antivirus. We always have to see that influenza, is there an associated myocarditis? Is there a CAD which is developed? Is there associated heart failure? If these are adequately treated, then we can see that the patient is not showing adequate response to the antivirals. In this case also, I would like to see all the parameters. So what I will be also seeing is that is the patient because of the respiratory illness, has there been an AKI and CKD, and that has given rise to a fluid overload, and that is the reason the patient is hypoxic. So oseltamivir, we reduce the dose to once a day, and I would just take it with so we can monitor the patient for the next 6 to 12 hours, since we are already admitting the patient, and taken a call gradually. So like remdesivir is not upfront, but in case we're thinking and a COVID is positive, we will be giving that. But we have to see for the other parameters as well.
You'll also investigate for atypical infections as well.
All bacterial and everything. So I would also err on the side of giving a basic antibiotic, a cap. So community-acquired pneumonia, the virus, the bacteria should also be considered, and that will be given to this patient, and we can de-escalate. Yes, sir.
Vrushali, you are absolutely correct. Give a practical scenario: a patient is sick, who has walked from England, he's affordable, he goes straight to the ICU in this kind of a scenario. You are going to do everything another 24 hours to reach at the diagnosis. You will have COVID RT-PCR, you will have H1N1, you will have the echocardiogram, you will have a cardiology opinion, you will have a nephrology opinion, you will have all set of parameters set, and your line of action is drawn in another 24 hours. Whether to use remdesivir or whether to use oseltamivir or to go on the guidelines of sepsis guidelines to treat your patient. This is how you are going to give the message to the masses when this kind of a patient walks into you. Whether it is a nephrotoxic or it is a liver toxic, these all things are apart from when you have to save the life of the patient. What I tell the patient is, if patient is there, liver is there. If patient is there, the kidney is there. You will fight to save kidney, and patient is gone. What we have gained at the end of the day. So remdesivir, if it is a nephrotoxic, hepatotoxic, but it is a lifesaver, you will give a chance to remdesivir to save the life rather than let the things go because it has got its own toxicities. This is my
Chawla, my point was calculating the creatinine clearance and deciding the dose. My point is not giving it to the patient.
Agreed.
Yeah. So my point was, you give a perfect diagnosis. Meanwhile, you calculate a creatinine clearance and give a perfect dose according to the creatinine clearance. It was
Correct.
looking at a nephrotoxicity and trying to save the kidneys or trying to save the liver. So, I'm sorry. So let me just concise and summarize what Vrushali, Supreet, Dr. Chawla, and Ravi has said. So this is a patient of a chronic kidney disease who's traveling. So there is a travel history. When there is a travel history, all sorts of viruses and all sorts of bacteria needs to be evaluated. So basic investigation, X-ray, admission, of course, and a patient who has got 2 comorbid conditions. Admit the patient, basic investigation, X-rays, echo. Of course, you rule out a fluid overload. If the infection is bad, you also have to look for the AKI on the CKD. You have to monitor the urine outputs, monitor electrolytes and all the cultures. Also send RT-PCR for COVID, RT-PCR for influenza A and B. Once all those things are sent, then you can start the treatment upfront. Of course, an antibiotic in this patient. Of course, you can de-escalate if the cultures are sterile, but still, if you think that there is an ongoing infection, you can continue with, and if the patient has improved with that antibiotics, you can continue with the antibiotic for a stipulated time frame and then stop it. Give an antiviral depending on that RT-PCR. If the turnaround time is less, if you get it in 30 minutes or maybe in 2 hours, you can always wait for the first shot because that's not going to be a life-saving. And of course, the supportive management, as Ravi said, fluids, if whatever is needed, fluids or diuretics or oxygen and even a non-invasive ventilator. Does my panelist would my panelists like to add anything else to this?
No, nicely covered. Very nice. Very nice.
So, Sonia, very well summarized. And like we were just saying, the window where we are observing the patient for 6 to 24 hours, if you have a rapidly worsening patient, we give everything. If it is not, we can take it as the investigations and the support system helps us.
It all depends on, then the multidisciplinary, we have a nephrologist, we will also have a cardiologist, and you have a physician and intensivist team. And then as the patient, progresses, we have to decide what is the line of management at that point of the time. Right? Okay, let me come to Shweta now. Shweta, this is a case scenario for you. This is a 51-year-old male, a non-diabetic hypertensive, controlled on patient's presence with acute respiratory illness or influenza-like illness, SpO2 92 on room air with fever and excruciating dry cough. Non-diabetic, okay, 51-year-old. His RT-PCR for H1N1 is positive and X-ray shows bilateral infiltrative lesions. Where would you admit this patient?
Seeing to the age, patient is only solely hypertensive, non-diabetic. The patient is desaturating, the saturation is less, but still he is not into respiratory distress. Patient has tested positive for H1N1. For such kind of patient, we would like to have ward admission, keep him under observation, start oxygen, start all the supportive treatments, start antivirals, and see to the progression of the disease. But such patient should be admitted in the wards.
Vrushali, would you start oxygen in this patient?
Saturation is 92, you said, right?
Yes. 92 on room air.
It depends on the respiratory rate is too high, then probably oxygen. Otherwise, I am generally miser with the oxygen also.
Dr. Chawla, what would be the target saturation that you would aim at in such patients?
This patient will go in ward in isolation with oxygen therapy at 1 to 2 liters per minute to maintain it around 95 with all what Dr. Gargiya has said about the symptomatic treatment you will treat. Yes, at 1 liter, 1 to 2 liters of oxygen, patient will be in isolation in the ward.
Ravi, do you agree to this?
Coming over here, can we
Ravi?
go in for a blood gas and decide on the the PaO2 rather than the peripheral? There could be so many reasons with the oxygen put on the lower side.
Oxyhemoglobin dissociation curve differs after the saturation is less than 90. So
Yeah.
in 90, the PO2 is going to be well acceptable. Your thoughts on this?
In front of you, when you see the face of the patient, you know this patient needs or he doesn't need, right? Say oxygen dissociation curve, say the PaO2 of 90 with PaO2 of 90 and PaO2 of 65 is matching with the ABG. this patient practically when comes to you, you are going to use it. If I am there, yes, 1 to 2 liters, I am going to use the oxygen.
Ravi?
Yes, ma'am. Saturation monitoring and respiratory rate monitoring, depending oxygen needs to be instituted in this patient. That is all.
Supreet?
Ma'am, I beg to differ. I think patient should be in ICU because he's got a saturation of 92 and bilateral infiltrates. And we know H1N1 progresses very fast. So the patient who have got a pneumonia, I think the pneumonia is because they have type 1 respiratory failure. And this patient, NIV doesn't work. NIV fails. So I think this patient should be observed because they rapidly deteriorate and has to be mechanic. They have to be ventilated upfront. No, that is my point of view. Patient should be in ICU.
Can I just put in one point over here? Now,
Vrushali?
also differs between how your institution is equipped. You know,
Yeah.
what are the kind of residents who are there in the wards? How is the staff to this ratio, and how are they trained? So possibly people like me who are in a tertiary care with DNB residents, and otherwise also I would like to monitor this individual in the ward, and in case there is a deterioration which we are monitoring for, we can quickly shift to the ICU. Also, I have the luxury of initiating them on non-invasive ventilator in the ward itself with a good respiratory therapist team as well. So I think I would err on the side, or I would rather keep the patient in the ward. Good for the psyche of the patient, and for the oxygen, if the patient is tachypneic, yes, oxygen. If the patient is not really tachypneic, like Sir said, watch the face of the patient. I would observe the patient with just antivirals and supportive therapy.
So let me come to you, Vrushali. What's your view on the conservative oxygen therapy versus the liberal oxygen therapy in respiratory phase? Hypoxic respiratory failure.
Okay. So Sonia, if a patient has, if the patient has an already pre-existing kind of a lung disease, I think it is very clear as to what the oxygen, you should be conservative.
What should be your targeted saturation in any of the patients?
So the targeted saturation I would expect, so based on what it was, it's 88 to 92%. And I would also be looking for the respiratory rate of the patient, which is solely dependent on the respiratory. You can have other reasons of tachypnea like AKI. So acidosis can give rise to tachypnea. Just fever can give rise to tachypnea. So those things. So for a patient who is chronic, 88 to 92% is what I would really go on. I am not in the liberal oxygen therapy reason unless you have an ongoing myocardial ischemia or there's any such condition where it warrants that the patient should be getting oxygen.
So there are guidelines that now the conservative therapy is the choice where you target saturation to 92 or maybe little more than 92. And if the patient has got hypercapnic respiratory failure, then probably it's 88 to 92. Right? Okay. So Shweta, again come to you, the same patient. What would be your therapeutic approach for this patient?
Ma'am, for this patient, I would like to go with start with the antiviral treatment because he is being tested positive for the H1N1.
Sure.
Apart from it, the supported treatments, as said, steroids. If the patient is maintaining good, then I would not like to add steroids at this stage. And
if the patient desaturates, will you add steroids?
Yeah. As such, the guidelines does not support steroids, but in my clinical practice, yes, I will add steroids.
And antibiotics?
Not. I'll not add antibiotics.
I want the view from the panelists. Ravi, would you add steroids here?
No, ma'am, I wouldn't add steroids, but I would add a broad spectrum antibiotic in this case.
Okay. Dr. Chawla, sir?
You must hold on to steroids because they are going to make your patient bad to worse. You hold on till they are life-saving. You are helpless totally. But at the same time, for secondary infection, doing a procalcitonin, seeing the infection, whether there is an infection or no, you are safe if you are using antibiotics where another one will not use it. But using steroid, you have to think 2 times.
Dr. Batra?
Yeah, ma'am. Same. I will start an antibiotics, but steroid I will hold on. And if it desaturates further and do an ABG&C PF ratio, then if it is less than 90 or PF ratio is less than 300, then definitely I will put him on steroids.
So let me summarize. The steroids have not been recommended in any of the viral illnesses except for the COVID. So let's start this as a patient who is already H1N1 positive, maintaining saturations of 92 on his own on a room air. According to again, we follow the IDSA pneumonia guidelines because this is a viral pneumonia illness. So according to this CURB 65 patient, earns an admission, but he goes to the wards. And then there is a close observation into the wards in an isolation ward. You look at the saturation, you look at the respiratory rate, you look at the pulse and everything. The patient deteriorates. Of course, he gets shifted to the ICU. You also send all the cultures to rule out the other infection. You can get a CRP, you can do a procalcitonin and then see. It would be an institutional practice or institutional selection of a use of an antibiotic, though not recommended at this point of the time. But there is no harm in giving an antibiotic also to prevent a secondary infection. But there is always a no for the steroids because this is an influenza and H1N1 respiratory illness and not a COVID-19. I hope I have summarized this properly.
There's an absolute recommendation against use of steroids.
Exactly. Steroids are not used in any of the viral illnesses.
If patient is an ARDS, I think then there is a recommendation. But otherwise, there is no to steroids.
There is no recommendation for ARDS as well. There is no recommendation unless the patient goes in septic shock and there is an hypotension. So the
it is not responsive to steroids.
Exactly. It's 200 to 300 or 400 milligrams per day only in septic shock. You should not give steroids in any viral ARDS also. Except for the COVID, there is no recommendation for the steroids.
Actually, I'm extrapolating from that because many people after that we have started because we extrapolating that definitely there is no. For audience, it's no. But I'm extrapolating on the COVID. We have the COVID when patients who are going in hypoxia or in ARDS, then only in those cases as a rescue therapy we have used. Otherwise, there is no.
I think we give a maximum respiratory support.
What Sonia has said, there is absolutely correct. Viral illness is no role of steroid. Don't give wrong message and extrapolation and I will use another use. The message is clear. What she has said is correct. There is no role. Thank you very much. We stop here for this kind of a case. Who is earning a ward admission in isolation? There is no need to presume that he goes in respiratory failure, goes on ventilator, goes on this. That is the reason I'm taking the patient to the ICU. ICU cost incorporated is a lakh of rupees per day as compared to the ward of 10,000. If you are in a private setup, patient is paying through the nose. If you are in a government setup, you are liberal to use. So no need to imagine if patient is stable, on oxygen or without oxygen with 92, stays in the ward, there is no role of steroids. Clear. It's very, very clear about it. And I think this is the message you should go.
So, if my panelists permit, I have got this recent Ministry of Health and Family Welfare report on influenza 2023. And I would like to read, if you all agree.
Sure.
So this is the latest report that I have on my hand. It is India every year witnesses 2 peak season influenza. One is from Jan to March and other is post-monsoon season. According to the latest data available on the Integrated Health Information Platform, a total of 3,038 laboratory confirmed cases of various subtypes of influenza, including H3N2, have been reported till 29th of March 2023 by all the states. Further, acute respiratory-like illness and influenza-like illness, 3,97,814 cases were reported in January and 4,36,523 were reported in February 2023. The corresponding data for admitted cases for severe acute respiratory illness, that is SARI, is 7,041 in January, 6,919 in February and 1,866 in the first 10 days of March of 2023. In 2023, a total of 955 H1N1 cases have been reported across the country, and majority of the H1N1 cases are reported from Tamil Nadu, which is 545, Maharashtra 170, Gujarat 74, Kerala 42, and Punjab 28. So this is just these are the figures which I've got it from the Ministry of Health and Family Welfare. And this is only for the first 2.5 months of 2023. So imagine, dear friends, how it is going to be devastating post-monsoon also if we don't follow all the rules and regulations, what Dr. Chawla, what Dr. Dosi has been alluding, and also if we don't take a vaccine as Dr. Batra has said, and if we don't go to the doctor and get a prompt investigation and prompt treatment as Dr. Vrushali and Dr. Shweta has said. So, friends, I want last editorial points from each and every panelist now. Take-home message and editorial points for each and every from each and every panelist for our audience. Dr. Chawla, sir, you first.
Thank you. I am very thankful for the youngsters talking very nicely. Supreet talked very nicely on vaccination, Ravi on management, Shweta on the introduction, you on epidemiology, have put in very good points, and the strong, you can say, the knee of the building was created. And top of it, Dr. Vrushali's inputs and your panel discussion has been fantastic. I'm thankful to the CCI, Dr. Krishna, for inviting me here. I take this opportunity on his behalf to invite you all in my NAPCON 2023 Delhi, purely academic feast, following CCI pattern, all youngsters to become faculty. This is the time for all of you. I am sure this may come or may not come opportunity to do this offer. We are closing on 30th of June. I am very, very thankful again to Krishna Bhai. The message what now she is expecting me to give, follow COVID appropriate behavior. You will be safe. It's not that it is a COVID time. The behavior, what we used to follow, the hand wash, use the mask, don't avoid the crowded places, avoid too much travel to the crowded places, I think still holds true. Seeing the horrible data, what Dr. Sonia has given to us with her efforts from Ministry of Health, I think at least being in health industry, we must follow this. Thank you very much.
Thank you, sir. Dr. Ravi?
I would just like to emphasize that we need to use antivirals very, very carefully. Antiviral resistance is not a joke. It is tough. And the other medicines, they are very difficult to get. So whatever we have, you should use our antivirals very carefully.
Dr. Vrushali?
So like one is prevention. So masking, distance, avoidance of overcrowded places. Secondly, vaccination is very crucial and it should be given to the care, the patients which Dr. Supreet has very well told us. And I think we should always make it a point to see who deserves an antiviral, who deserves an investigation, who deserves to be admitted. Even if we are not admitting some individuals, it's very important, like Sonia said, that we monitor them closely for the next 7 to 10 days.
Batra?
Yes, ma'am. I just read the report. What you said, I also read the same report. Just to make a pointer that the vaccine we have, it does not have efficacy against H3N2. That's why we are seeing peaks. There was a multi-centric trial published in Lancet. The vaccine is having 60 to 70% efficacy against H1N1 and influenza B virus. But against H3N2, its efficacy is only 30%. And when there is an antigenic drift, it goes to 20%. So that's why I think the vaccine is not effective against maybe the answer. That's why we are seeing a surge. And regarding this, I will say everyone should take a vaccine. It is preventive, and we healthcare should take this opportunity and vaccinate first ourselves, because there's a grade 1A recommendation for us also, because we people usually ignore ourselves. So first we should, I think, protect ourselves. Then only we can protect and save our patients. Thank you.
Can I just comment this H3N2? This H3N2 is basically by default has a lot of antigenic drifts which are ongoing. And in addition, and in addition, whenever you have these egg-based vaccines which cause a little bit of change on the antigen. And the third thing which they have also pointed it out is that if the time when your vaccine, which virus is included, is decided to the time the vaccine is doled out. This is a period of 6 months. So So multiple factors, but H3N2 is the one which usually evades the immunity.
And there is an
Irrespective
update
of
also.
that.
There is an update also. There is an update also. There's a universal vaccine. Its trials are going on which is antibody against the preserved portion, because there's an antigenic drift and shift. So to overcome, there is a vaccine trial is going on, which is produce antibody against the preserved portion. So that vaccine, if comes, then drift and shift won't matter to us, and then there will be a universal vaccine for all of us.
Irrespective of whatever it is, we all need to vaccinate ourselves. That should be the message, which is very loud and clear. Right? So we know, all of us know the microbiology. We know what is antigenic drift, what is antigenic shift. But what we have to tell our patient is not about antigenic drift and shift. We just have to tell our patient that you need to vaccinate yourself, whether it is 40%, 60%, or 20%. Whatever. In spite of us taking COVID vaccines, most of us got COVID, but we got away with that serious illness. So what is important is, irrespective of whatever it is, we have to recommend vaccines to all the comorbid conditions, vaccines to airway disorders, vaccines to ILD, vaccines to all those patients who are elderly, right? Shweta, your last message, please.
Prevention is always better than cure. So apart from the prevention, we also have to choose our patients very carefully. The treatment we choose for our patient is very much important, and we should always educate our patients for vaccination.
Thank you very much. So I also learned a lot from my panelists today. And in the end, I would like to just say a quote by Goethe, who has written the history of influenza pandemics. He has very nicely alluded, knowing is not enough, we must apply. Willing is not enough, we must do. Ladies and gentlemen, friends, it is very, very imperative that we keep our eyes open for flu-like illnesses, respiratory illnesses. We need to treat, we don't have to treat each and every patient. We don't have to investigate, but yes, a close monitoring is very important. And all those patients who are immunocompromised or immunocompromised therapies with comorbid condition, they have to be seen with a pinch of salt. You have to either admit them. You can also think of giving them an empirical antiviral till you wait for the reports of RT-PCR. And of course, you can also do an RT-PCR in a patient who walks into your OPD has got comorbid conditions. Please use antibiotics with a pinch of salt, or with little risk.
Tons of salt.
Yeah. And no steroids in flu-like illnesses, please. So any viral illnesses, no steroids. You need to admit those patients with comorbid conditions whose saturations are falling, who are a respiratory tachypneic, who has got fever not coming down, with comorbid illnesses with immunocompromised status. And this is my take-home message for all of you. Thank you very much. It was fantastic indeed, talking with all of you and sharing my views as well.
Thank you. Wonderful.
Thank you all. Thank you so much. Yeah.